Well, good evening, everyone. Thank you so much for joining us tonight for the Lupus Foundation of America Chapter Network's Let's Talk About It webinar series. My name is Maggie Maloney. I am the Programs Manager at the Lupus Foundation of America Philadelphia Tri-State Chapter, and we represent Pennsylvania, South Jersey, and Delaware tonight. And I'm joined by Dr. Linda Brecher. So thank you, Linda, or Dr. Brecher, for joining us tonight.
Linda's fine.
I never know what to do.
So it is my pleasure to be here.
Okay, great. So just some housekeeping. If it's your first time on one of these Let's Talk About It webinars, each month the Lupus Foundation of America Chapter Network gathers together to discuss important and relevant and requested topics related to lupus from experts across the country. So tonight we'll be discussing lupus and your bone health. And as the title says, osteoporosis, know your risk. So before I introduce the presenter fully, I just want to remind everyone tonight that the information presented in the webinar is for general information and educational purposes only. It's not a substitute for your physician's advice, and the views expressed by this webinar presenter is those of the presenter and not necessarily those of the Lupus Foundation of America. This webinar is being recorded right now. It will be edited and available later this week from your local chapter. So if you have any questions, you can either type them in the chat or the Q&A section tonight, and we'll get to them after Dr. Brecher's presentation. So if you just want to type it though, I'll make sure to keep a note on it. And if you do have one that's very specific to your lupus in particular, you can answer the question, but we are going to prioritize those questions that are a bit more generalized. And if you have further questions unrelated to tonight's webinar, feel free to put those in the chat as well, and I can try and get you in touch with your local chapter if you do not know what your local chapter is. So with that, I am pleased to introduce Dr. Linda Brecher. Dr. Brecher is a Division Chief of Rheumatology at the Rowan Medicine Department of Medicine, located in New Jersey. She is board certified and fellowship trained in rheumatology and offers extensive experience in the diagnosis, treatment, and management of rheumatic diseases and conditions. Dr. Brecher attended medical school at the Des Moines University College of Osteopathic Medicine and completed a residency at the Delaware Valley Medical Center and a fellowship at Hahnemann University Hospital. Dr. Brecher, with that, I'm going to turn it over to you.
Great. Thank you so much. Well, I'd like to welcome everybody here, and I'm hoping that I'm going to provide you with a great amount of information that you'll be able to take up and use in your own healthcare. Osteoporosis, know your risk. Know your risk, know your numbers. We've been saying about that in medicine for a very long time, that we are the keepers of our healthcare. And the more we understand about our healthcare, the easier it is for us to modify what we need to do in order to do the right thing. So this is one more of those things we're going to say, know your numbers. And in bone health, the T-square is the number we need to know. We understand blood sugar, blood pressure, cholesterol, but I'm going to teach you more about how we measure bone health and bone strength and how we work every day to maintain the best health we can. So what you need to understand is we think of bone as just sort of being there. We understand it's important, it holds us up, it keeps our organs protected, but it is living tissue. And if you look on the left, when you're very young, bone is growing because we're getting taller, our bones are getting denser, they're growing with us. But then what happens is we hit what we call peak bone density, and that typically occurs around the age of 30. And that's basically the best it's going to get. It's important in young life that we put a lot of energy into giving our bones the healthiest chance to get started and grow to their potential peak. Once we've hit our peak in our early 30s, we are typically not going to get any stronger or taller. We know you've pretty much hit your maximum adult height. But what happens is there is a rapid loss when we end our estrogen years. So whether it be a natural menopause, whether it be a medication-induced menopause, or whether it be a surgical menopause. And when we talk about menopause, it's not just the loss of menstruation, it really is the loss of ovaries. So while some people may have their uterus removed, they still have their ovaries, so that's not menopause. So menopause is the loss of estrogen. And bone is stimulated by estrogen. There's estrogen receptors on our bones. So when we lose that stimulation, bone starts to develop further bone loss, and you'll understand that the structure changes, and that's what causes osteoporosis. So from the last exposure to estrogen, in the next 10 years, people can lose up to 20% of their bone density, which I'll show you pictures about that. And understand why I talk about women right now, because osteoporosis has always been associated with women. It's equal opportunity, and I will give you some ideas later how men can be affected by osteoporosis too, either by their underlying disease, by age, or by medication. So bone strength, it's not the way it looks, it's the way it holds up and holds together. If you look at healthy bone, on a good day, it looks like a sponge. This is called trabecular bone. And trabecular bone is the type of bone that we have in our vertebrae that make up our backbone, in our hips, and at the end of our long bones. So if you know anybody that ever fell, put their hand out to break their fall, and broke their wrist, that is trabecular bone. It's the end of the long bone. So these fractures that occur from osteoporosis occur in trabecular bone, primarily wrist fractures, hip fractures, spinal fractures, and then sometimes we see shoulders and pelvis fractures. What determines how strong your bone is? As I said, meeting your peak bone density in your 30s. If you've been healthy and you've done everything right, you're going to make your peak bone density. And that part of that is genetic. It's who you come from. So if you're small frame and very petite, your peak bone density may be good for you, but it's not going to be as strong as somebody who is large frame. Nutrition strongly affects your peak bone density. It's important through our lives that we get enough adequate nutrients. And that includes calcium, vitamin D, adequate protein sources, just doing the right thing. Physical activity, what's very interesting about bone is that it's stimulated by us opposing gravity. If you hear the stories about the astronauts that go up into space, when they come back from space, they get a bone density test, because when they're not living in gravity, they rapidly lose bone density. So what we need to know while we live on the earth, anytime we are standing, we are opposing gravity. So any activity that requires your feet on the ground is healthy for your bones. That could be walking, it could be dancing, it could be jogging, walking in place, many things. Some other activities may not be as bone stimulating, like biking, because your feet aren't on the ground, but they're still healthy. And the last thing is, there are medications that we need to use, to keep ourselves healthy, that may negatively affect our bones. We don't really advocate that people stop medications, because I assume we're on things because we need them. So I always say life and limb, we have to figure out what's necessary. But as long as we understand that they may be factors influencing our bone health, we can work in other ways to monitor our bones. So the definition, osteoporosis. So it's a disease characterized by weakness, and then bones break. And it's a deterioration of the structure, as you saw in the past slide. Osteoporosis translates into porous bone. So bone loss is a natural part of aging, and that's because we, as women especially, lose estrogen. And we could stay on estrogen forever, but that's kind of out of vogue now because of other health issues. So we know it's going to happen, but we don't want to see fractures. And 9 million Americans over the age of 50 have osteoporosis, without symptoms for most of them. So understand, there are no symptoms of weak bones. The only symptom is breaking a bone. So we're trying to prevent that. So 50% of women and 40% of men will develop osteoporosis in their lifetime. And at this point, we're seeing at least 2 million fractures related to osteoporosis in the US every year. And that's surely 2 million too many. So osteopenia, one of my favorite pet peeves, when patients come in and they say, it's only osteopenia, that's what they told me. Well, osteopenia means low bone density. It means you're not at your peak anymore, that you have lost some amount of bone density, whether it be a little or a lot. But half of the fractures that occur in low bone density are osteopenic, not osteoporotic, which is to say, some people with osteopenia should be treated because they are at very high fracture risk, but not all. there are many people with osteopenia that are not in high risk for fracture, and we don't like to start anti-reserve medication in people that really are not at fracture risk. So this is where your provider, your physician comes into play, looking at your bone density and helps to decide if you have osteopenia and should be treated. I would say it's not everybody, but it's a good time that I can educate the people in the office. Well, you know, you don't need treatment, but let's make sure we're doing all the right things, the calcium, the vitamin D, the fitness, the exercise, and then we'll repeat your scan in 2 years. And I'll give you some ideas. There's a tool we use to help to decide who needs to be treated. So who gets osteoporosis? Well, in the US, 53 million people have either osteoporosis or osteopenia or low bone mass. Big number. It affects women and men of all races and ethnic groups. And the risk factors that we're going to talk about, some of them you inherit, some of them are life-saving therapies, and other risks you can change. So we should really spend a lot of energy thinking about the things that we could do better just naturally in our day-to-day life in order to minimize further bone loss. So things you can change. Being female alone, that is a risk. Being past menopause, remember estrogen was stimulatory to the bone and now we don't have estrogen. If you are related to first-degree relatives that have osteoporosis, or if we think back to mothers or grandmothers, they might not have called it that, but I always asked, any first-degree relatives ever break their hip? So hip fractures are a super high risk. Unless it was traumatic. Now, a car accident, falling down the steps, I don't mean that. These are called fragility fractures. People that fall from standing height, even if it's icy, fall from standing height and break something is considered a fragile or a fragility fracture. So any family member who had osteoporosis related fractures, hip fractures, wrist fractures, spine fractures without trauma. Being thin, small, or petite, and that's because your frame is tiny and kind of the cutoff has been around 128 pounds. And we're talking about your age at 30. So if you were small frame at 30 and then you gain 20 or 30 pounds later in life, those pounds don't protect you. We're going to your 30-year-old age because that's when we realize that your skeleton frame is small. Age affects our bones. You know, we can't get away from that. And then other health conditions. And in these conditions are a lot of inflammatory disorders. So, and I have to put lupus in there too, because it's disease of inflammation. Inflammation sends out chemical messengers called cytokines, and cytokines are inflammatory, and they have a negative impact on your bone health. Celiac disease. You know, we know that people with autoimmune disease have overlap sometimes of more than one autoimmune disease. So I have lupus patients that also have celiac, and they have Hashimoto's or underactive thyroid. So all of these are inflammatory autoimmune. Inflammatory bowel disease, that's a risk because again, inflammation. And then the last that I mentioned is COPD or emphysema or asthma because they're inflammatory in your lungs. So inflammation in and of itself produces cytokines which increase bone resorption and add to bone loss. Now, controlling the inflammation is always our goal. So that will be a positive influence to control the inflammation. But some of the medicines we use to control inflammation kind of have a bad effect on bone, and I will go over that. So anybody who's had a fracture or a broken bone after the age of 50 without trauma. So, you know, forget it. If you were on roller skates and you fell down and broke something, that's trauma. Fall down the steps, trauma. Car accident, trauma. But walking down the street and twist your ankle and end up breaking something, that's not trauma. Any fall from standing height that results in a fracture should be assessed for weak bones or osteoporosis. Certain medications, and I understand that many of these medications are life-altering and life-sparing and life-saving. So corticosteroids, prednisone, methylprednisolone, Medrol, Solumedrol, they have a very negative impact on bone, but we don't use them unless they're needed. So we kind of put that in our list of, well, we know it's a risk, but we have to be on this medication because it controls disease. So our goal is to be on the lowest dose that's necessary to control disease. Anticonvulsants are anti-seizure medication, and nobody takes them for fun, But again, it's on our list of it may contribute to risk. We always want to know what our risk is so that we know how to manage it. Antacids, very specifically those called proton pump inhibitors. They're medications like omeprazole, Prilosec, Nexium, Protonix. And these are super good medications to control intractable heartburn. But what they do is they do it by lowering the acid inside your stomach. And that's how they control reflux and heartburn. Well, what we have found is they have a twofold negative impact on bone density. One is most calcium supplements that we take that are over the counter are only absorbed if there's acid in our stomach. So if we're on a very strong acid inhibitor, our calcium supplements may not be helping us at all. And that's not dietary, because dietary calcium doesn't require acid, just calcium carbonate supplements. We also think proton pump inhibitors have their own negative impact on bone. But again, nobody should be on these medications unless they have to be. Sometimes I have people, their symptoms are totally under control. I have them talk to their provider, their gastroenterologist, their primary doctor. And if they don't need a proton pump inhibitor, they can move over to like a H2 blocker, Pepcid or Tagamet. Zantac was taken off the market, but those acid blockers are not nearly as strong as proton pump inhibitors. The other risk is falls, because in order to break something, it takes usually two different factors. One is having weak bones, and the other is the fall. So don't ever underestimate how important it is to work on balance and strength and safety in your home, because we usually fall over things that are silly, you know, whether it be a pet or a throw rug or extension cord or a space heater. Got to be super careful, especially at night and getting up quickly. So what can we change? Well, calcium is a mineral, and we know that 90% of our skeleton is made of mineral, and that mineral is mostly calcium. So if we don't get enough calcium in our diet, our body knows where to find it. It goes to the bank, and the bank just happens to be your skeleton, and mostly your trabecular bone, which is what we talked about, the hip, the vertebrae, the wrists, the ends of the shoulders. So why do we need calcium? Well, it is a necessary mineral for every type of activity that our body needs energy. So energy is taking a breath requires energy, and energy is measured in ATP. So in order to contract your heart, contract your muscle, every single time you do one of those things, calcium is being used. It has to be there. And if you don't get enough in your diet, your body's just going to go to the bank, and every day you're going to have a withdrawal. And those withdrawals may be slow and they might be small, but over a long period of time in a lifetime, it could add up to worsening bone density. The other factor is vitamin D. We know in order to absorb calcium from our gut, we need vitamin D. So if you're vitamin D deficient, you may not be absorbing the calcium that you're taking in. Exercise, very, very important, mostly for balance, fall risk reduction, just overall conditioning. Exercise can be anything. Like I said, weight-bearing exercise is probably the most important for your bones. Smoking has a very negative impact on bone density and other health factors. So we really encourage people to consider smoking cessation. Alcohol has a negative impact on bones, on hormones, and also the risk for falling. So 3 or more alcoholic drinks a day has a negative impact. And the other thing is excessive intake of caffeine, because caffeine is not healthy for your bones. The last thing, which I didn't have up here, is colas. So there's phosphates in a lot of carbonated drinks. It's most of the highest amount is in colas. So we try to avoid too much soda or pop or whatever you might call it. The seltzers that don't have cola in it are free of phosphates, so you can feel comfortable doing that. But too much caffeine, too many cola drinks have a negative impact on bone. So fractures, that is equal to broken bones. So a fracture and a broken bone are exactly the same thing. And there's over 2 million a year in individuals with osteoporosis or low bone density. And as I said, it's simple things: fall from standing height. I've seen people turn over in bed to grab the pillow and they fracture their vertebrae. I've seen people get up and go to open a window and bend at the waist, and as they open the window, they have a crush fracture of their vertebrae in their back. Very painful when these occur acutely. Wrist fractures. So the very end of the wrist, where, you know, by your thumb, is the most common wrist fracture. It's called a Colles fracture, probably after Dr. Colles. This tends to occur in younger women right around menopause with low bone density. Once you have a fracture, I don't care what your DEXA says, you have osteoporosis. Once you've proven that you could have a fragility fracture for no other reason, suddenly your osteopenia now becomes osteoporosis. What we have found is that wrist fractures are most common in women from like 50 to 65. And after 65, we see very few wrist fractures. The reason being, as women get older, they don't have that reflex and they don't get their hand out fast enough when they're falling, and they end up breaking their hip. So hip fractures rise at 65, wrist fractures go down, not because wrists are getting stronger. Vertebral fractures, that is a fracture of the vertebrae that makes up your backbone. It can result in a great deal of pain. It can cause deformity because what happens is the front of the vertebrae crushes, the back stays high. And once you have a few of those, this is where people get that typical curvature where they can't stand up straight because of the postural deformity. Now, what's interesting is that 2/3 of vertebral fractures occurred without pain. We do a chest x-ray and somebody says, wow, you have a couple of fractured vertebrae. And we say, I've never had a broken bone. I've never done it. It's remarkable and hard to understand how 1/3 of the people that have a fracture can have such severe pain, and 2/3 it happens without symptoms. And I don't have a great explanation, and it really does not have to do with having a high pain tolerance. It's not, but it is just fascinating. So sometimes when people have postural deformities, it's super helpful to get an x-ray, just a lateral spine, to make sure that the postural deformity is not from vertebral fractures. Now, hip fractures almost always require a hospital stay, and they almost always require a major surgery to put a pin in the hip and or a hip replacement. Now, hip fractures tend to occur later in life, usually over 65, and the rate goes up the older over 65 you get. And because of the aging population and the fracture, we have found statistically there's a 20% increased risk of dying within the year after a hip fracture. But that also, we've got to take into consideration general health, you know, what other medical problems are going on. I mean, I have people that are 75 and 80 and they are in great shape and they break their hip, they get it pinned and they get back to life. But you see people with multiple health problems. They don't really do very well through the surgery or the rehab. And sometimes they don't walk independently again. Now there's a walker, or they can't live alone anymore. So, you know, hip fractures are pretty devastating. So how do we evaluate people for osteoporosis? Well, in my office, it's, you know, a complete history and a physical exam. I spend a good hour with patients trying to educate them like I am with you so that they can actually own this, that they understand their bone health and they can be proactive in the care of their bones. We have so many responsibilities in taking care of ourselves, but the body is just a wonderful machine. And if we don't take care of it, bad things happen. So we order a bone density test, which we call a DEXA, and it's actually, there's no E in it. We call it a DXA, that's a DEXA. And that tells us a lot. And I'm going to go through that with you so that you understand what these numbers mean when somebody tells you what your T-score is. But I like to give guidance in calcium and vitamin D. And one of the most important things I want you to understand is there's an amount of calcium that we need every day. And when I give you these numbers, I'm really talking about somebody with normal kidney function and no history of kidney stones, because that population is going to be a little bit different. But in somebody who's otherwise has normal kidney function and they don't have kidney stones, we really recommend anywhere between 1,000 and 1,200 milligrams of calcium a day in postmenopausal women. So after the last menstrual period, postmenopausal, that's what you need, 1,000 to 1,200. Now, The best type of calcium is the calcium we get through food. We know that our body is very, very good at getting nutrients from food. It's probably the best absorbed type of calcium, the most natural, and it works the best. That being said, not everybody can tolerate a lot of dairy products, and dairy is our biggest source of calcium. So then I'm willing to bargain half and half. Let's try and get half in your food, you know, some of the greens, some almonds, sardines. But again, the mother load of calcium is going to be in a dairy product. 8 ounces of milk, any kind of milk, is about 280 to 300 milligrams calcium, which is a lot. So we need calcium, we need vitamin D. The amount of vitamin D varies person to person. A lot of people are D deficient, and we don't know that until we check their vitamin D levels. So I do feel that when we're doing bone density evaluations, checking a vitamin D level is important. Calcium, one other thing I want you to remember, this is so important to me, is that if I say you need 1,000 to 1,200, there's a lot of people that'll go out there and they'll say, well, I'm going to get more, because if a little is good, a lot is better. And that's completely not true when it comes to calcium. You have a daily need, and that's what you should get. But trying to get extra, especially if it's supplements, if it's vitamin extra, it increases the risk for kidney stones. So trying to be a high achiever in terms of calcium intake, just thinking you're going to get better bone health, is really a misperception, because calcium never, ever, ever goes back to the bone. It's either in the bone or it comes out of the bone, but getting extra is not going to find its way back. So try to get enough without getting extra. And if you get enough in your food, I think you get a gold star, because food is the best source. If you can't get enough in your food, then you'll use supplements, but try not to use only supplements. They're not as well absorbed as dietary products. I talked about fall risk, super important, things that make us fall. You know, we should have hand railings on our staircases. People that are unsteady should have grab bars in the shower, by the toilet, you know, all the things that can take your balance away. Don't ever stand up too fast. If you could get dizzy, that could cause falling. Super careful. Try not to wear flip-flops. Try not to wear shoes without a back on them. Don't put your slippers right under where you get up in the morning. There's a lot. Don't stand on one leg, you know. Go to a chair when you're putting your pants on. Be careful, especially if you know that your balance is off. Sometimes I'll refer people to physical therapy for balance training, to teach them exercises to help them keep 2 feet on the floor and decrease the risk for fall. Exercise, balance training, again, very, very important. We can't minimize that. Our physical strength is super important to keep 2 feet on the ground. What I see a lot in as we age, and me included, I'll be walking down the street and go to step up on a curb and maybe not get my foot high enough and hit the curb straight on. I can't say it's a weakness because I work out all the time. Maybe it's lazy or fatigue, but I have to be super careful, because you hit that curb straight on and you're a projectile object. So be careful. So prescriptions, there are prescription drugs. I'm sorry to say there's nothing else that we know in nature that will build back bone density other than medication. So it's a big job I have, trying to convince people that need medication that it's important that we do it. And if it's needed, I think we should do it, because if we get your bones stronger, you'll enter your next decade with stronger bones, because as we get older, our risk for fall and fracture only goes up. So trying to treat people, not over-treat people, but treat people when they need it is super important. And then the last piece is I usually see people back to make sure that they're tolerating whatever treatment. And depending on the treatment is when we decide to see them back. Some people I see once a year. Some people I see every 6 months. Some people I see a month after starting medication. So the decision for medicine is very individualized with each patient and their medical history and their kidney function and what other health problems they have. And we talk about the risk and benefit of all the treatments. All right, this is the important part, the DEXA. It is a really wonderful and simple way to measure bone density. So bone density is how many grams of calcium are in each centimeter of your bone. Because if you remember the picture, porous bone tends to have bigger cavities and less calcium and less mineral. So the DEXA, if you've ever had one, is a machine like this. This is a GE machine. It's painless. You usually don't even have to take your clothes off. It takes under 15 minutes. It has about 20% the radiation of a chest x-ray, so that's very low. And it gives us a great information about your bone density, how much density is in these sites. The sites we measure are the vertebrae in the lumbar spine, which is the lower back. Some people may lose in other areas, but the DEXA measures your bone density from side to side. It goes horizontal across you. So they have to be measuring an area that doesn't have other bone in the way. So if we go too low in the spine, we get the ilium, the wing bones on your hips, and then that will interfere. If we go too high, we get the ribs. So it's only L1 to L4. The 4 lumbar vertebrae are the only vertebrae that we can see with no other bone in the way. So that's measured. The other thing measured is always your hip, unless you have 2 hip replacements, but we try to get at least 1 hip measurement because hip fractures are so dangerous. And then in some cases, we'll do the wrist, the distal radius, because that's an area that tends to lose first. So the DEXA helps us to diagnose bone loss, osteoporosis, osteopenia, low bone density. And it also is helpful to monitor treatment. If we start treatment, we usually like to recheck the bone density in 2 to 3 years, because the bone density does not change that fast. And doing a DEXA every year, we may not catch the improvement or even the loss, because it's not long enough time to see the amount of change. But it can help us to predict the risk for fractures and treat. So what does it do? I told you it measures grams per centimeter. It measures the density, how much calcium is in the area of interest. It takes that number and it compares it to a total population of people that are your size, your weight, and your race at 30. Because we know that at 30 is when our bones are as strong as they're going to get. So it's comparing your density to that of a healthy 30-year-old that is your size and your shape. So if you're large framed, it's not going to compare you to a petite person. And if you're petite, it's not going to compare you to a large framed person. So it's important that we have the same body mass composition. And therefore, if we think you were at one point in the 30-year-old population, it will tell us how much weaker you are than a 30-year-old that looks like you. And that's what a T-score is. So if your T-score is 0, that means you are just in the middle of that 30-year population. So if you're 65 and you have bones of a 30-year-old, you're doing really good. But typically, once you're over menopause, you start to lose bone because you're way past 30 and you've lost estrogen. So that's where our T-score comes in. So a T-score from +1 to -1 is still considered normal because we're not all going to be in the middle. So we have this little margin of that's still normal. But once you get more negative than -1, so a T-score of -1.5, 1.8, -2.4, anywhere to -2.4 is considered low bone density. May have an increased risk for fracture. But once it gets below -2.5, you're down there on the negative side, it's osteoporosis, even if you've never broken a bone. And that's the time we really want to intervene and treat, because once you've had one fracture, your risk for another fracture doubles. And it just keeps going up like that. So how do we manage risk factors? One is we try to get adequate calcium and D. And as I said, calcium-rich dairy products are the greatest source. If you don't do dairy, if you can tolerate salmon in a can, not fresh salmon, but canned salmon actually has the salmon bones that are ground up in it. So you're getting natural calcium from the fish, from their skeleton. Sardines, like I said, almonds. Collard greens have a good amount of calcium. Kale has a little, broccoli has about 75, but you can always Google that for non-dairy sources of calcium. Kiwi actually has a little bit of calcium. And then the other thing is supplements. The important thing about supplement is you want something that is well absorbed. So if you have no GI problems and you're not on acid blockers, you can go ahead and get calcium carbonate, which is the most common type of calcium. Oscal, Caltrate, Nature Made, most of them are calcium carbonate. The upside is that it's very inexpensive. They usually come in a 500 or 600 milligram tablet. It is pretty well absorbed, but some people find it can cause constipation and bloating. So if that's your problem to begin with, the last thing you want to do is take a supplement that makes that worse. So then we recommend calcium citrate, okay, C-I-T-R-A-T-E, which is, every calcium is a salt, so it has to have two words. So carbonate is the easier one to find. Citrate, there's not as many people that make calcium citrate, but it's very well absorbed. It doesn't require acid for absorption. So if you are on an antacid, it might be the healthier calcium to choose. And it is pretty neutral to your gastrointestinal tract. So it should not cause the constipation, the bloating, and the gas that you might see with the other types of calcium. So just keep in mind, if you have trouble tolerating the supplement of calcium, look for calcium citrate. The brand name of the most popular one is called Citracal. It's like calcium citrate backwards, Citracal. It is well absorbed. It's a good supplement, but just beware that it is a very big square pill. It's a tablet that is oblong and has square edges. So they've made one called the Petite, calcium Citracal Petites, but then it's like a one pill cut in half, so you have to take two for each dose. So keep that in mind. Many people require vitamin D supplements. A bulk of my patients do, just to maintain a vitamin D at about 40. That's really my goal. And D is very inexpensive. Probably the best absorbed D is called D3, and it comes in multiple different denominations. There's 1,000, 2,000, 5,000. I say, talk to your provider, your healthcare coach, as to what you should be on. We don't want to ever take too much D, because D accumulates. So you don't want to just be out there taking 5,000 units of vitamin D a day if nobody's monitoring what you're taking or what you need. Exercise, very, very important for every part of your health. But again, muscles get stronger when you make them work. Now, strength training probably doesn't make your bones stronger, but they make your body stronger. They help your posture. Bad posture increases, the fact that we don't stand up straight increases the risk for vertebral fractures. Weak muscles increase the risk for falling. Weight-bearing activities, again, not to be like the astronauts and lose gravity. Postural exercises, balance exercises. The only thing I'm going to say is that if you have osteoporosis and you have low bone density in your spine, we really encourage you to not do exercises that require you to lean forward too much, because it puts stress on the front of the vertebrae and increase the risk for those compression fractures. So we like all of our activities to be postural and in extension. If you've ever done yoga, how they do the cat and the cow, we don't like the cat, because when you have weak bones, putting your spine up like that in that curvature increases your risk for fractures. And the last part, which I know I've mentioned, is fall prevention. We want to make sure that your house is safe and wherever you are is safe. I encourage night lights in the bathroom, so that if you get up at night and have to go to the bathroom, you have some way to see. Medications, and they come in multiple flavors, and picking a medication for each person is super individual, depends on their medical history, their health history, what medicines they're on, what they tolerate, and unfortunately, lastly, what the insurance will pay for. So estrogen, anti-resorptive, is the medicines that prevent further bone loss. Bone, like I said, is alive. So it is a combination of, I consider it sort of like the streets of Philadelphia. There's potholes all over the place. And if you think of your skeleton as having little micro areas of potholes, because that's what happens. It's micro trauma, things that you can only see under a microscope. But we have cells that are running around on the surface. And what they're doing is they're looking for these areas of trauma from lifting something too heavy, moving the furniture. When they find those areas, the osteoclast, which is pretty much our garbage collector, it binds to the surface of the bone and it starts to make a resorption cavity, or it takes out the soft bone. And it takes it down just like a pothole. It takes it down to clean tissue. And when the osteoclast is done, Then comes the osteoblast. I always think of osteoblasts because they build. The osteoblasts come and then they fill it in. And that is one whole cycle of bone turnover that is normal throughout our lives. You got the hole diggers, you got the hole fillers. What happens when we lose estrogen? We lose half of our fillers. So we still have hole diggers. We need that. We need resorption, we need repair, but we don't have as many hole fillers. So the problem is we have more loss than we have build. When you're very young, you have more build than you have loss, but you still have repair. So estrogen was the first anti-resorptive, meaning that it stimulates, it decreases the osteoclast activity. So there's less hole diggers and we have a better balance. But because of other health problems related to estrogen later in life, it has been no longer recommended for osteoporosis treatment unless you're already on it. Bisphosphonates, these are all anti-resorptive. So what they do is they interfere with the hole diggers. They interfere with the actual resorption. Not entirely, but they slow it down. So the medications that we've known by brand names of Fosamax, Actonel, Beniva, Reclass, generically alendronate, rucidronate, ibandronate, and Reclass is known as zoledronic acid. So the first three are pills, and the last one is an intravenous. And these are medications that actually try and change the bone balance. So there's more fillers and less resorption. And those medications can improve bone density like about 3 to 9% over the course of 3 years. And they've shown to decrease the risk for fracture, which is really the end point. That is our goal. In order to get approval as a treatment for osteoporosis, you can't just show that you make bone stronger on the DEXA. You have to show that you reduce the risk for fractures. So the next category is something that also works on the same cell, the osteoclast, right? The hole digger, and that's called Prolia. But it inhibits rank ligand, and that is a system that makes these baby osteoclasts grow into mature osteoclasts that then bind to the surface of the bone. So it interferes with the maturation of the hole diggers. So there's less of them. It doesn't shut them down, but it's still an anti-resorptive. It still works on the osteoclast. But Prolia is given as a shot in your arm, almost like a vaccine every 6 months. Calcitonin has kind of fallen out of favor because it was one of our very early treatments for osteoporosis, and it's a nose spray. It used to be an injection, and then they came up with a nose spray. And there's nothing bad about it. It can decrease the risk for spinal fractures, but what they found is it really doesn't help to prevent hip fractures. So if we're gonna be on something, we would like a product that will help all of our skeleton, not just our spine. And then there's Evista, which is an estrogen agonist. So it acts like estrogen on the bone, which is a good thing, because remember, estrogen is good for the bone, without causing any negative impact on the uterus or other things. But the medication probably is best at preventing bone loss in the early menopause than actually treating osteoporosis. The Evista 2 showed a decreased risk for spinal fractures, but not for hip fractures. So once somebody has outright osteoporosis, we usually stick to the products that have demonstrated a reduction in all fractures, which is spine, hip, and other sites, which would be like pelvis and shoulder and wrist. So really what we're using for the most part are the alendronate, the rucidronate, the Reclass, the zoledronic acid, the Prolia, which is called denosumab. They're pretty much the anti-resorptives that are used the most in my practice. And then this is the secret. If we look on the other side, anabolic agents are agents that actually stimulate the hole fillers. Remember, these are the guys that come and fill all the holes in. They're called anabolic. So anabolic is anything that stimulates growth. So instead of working on stopping resorption, this actually builds bone, which is a wonderful thing to do, but it's a little bit cumbersome. So there are 2 injectables that are synthetic PTH. PTH is parathyroid hormone, which is a hormone that comes from parathyroid glands. And if you give it every day as a shot, it actually stimulates bone building. it's a great idea. And sometimes I say, why don't we just make everybody have stronger bone? You know, the medications come at a cost, and the cost is huge. It's multiple thousands of dollars a month, and it's covered by a lot of private insurances, commercial insurances, but the coverage in Medicare, if you don't have commercial pharmacy, it's very, very hard to get it paid for. It's a cost that's prohibitive for most people to shoulder on their own. So these bone building agents, Forteo and Tymlos, are usually used for about 2 years to build bone, and then we transition over to another product that will help them keep bone. So it's a daily injection every day that's done at home. And then the last anabolic is something that's been on the market for about 3 years. It's called Evinity. It too is an anabolic. It's a bone builder. It had some wonderful, wonderful data that it significantly built bone. It's given as an injection in the office, 1 in each arm, once a month for 12 months. And the only hesitation, which has made it very difficult on the market, is that when they did a study, a couple thousand women with osteoporosis, there were more heart attacks and strokes in people that were on Evinity compared to those that were just on placebo. And that becomes a big, you know, it's a black box. It becomes something that has to be investigated. The numbers, even though I said they were double, they were very, very, very small, but they were still double. So right now the label says in people who've had a recent cardiac event or a stroke, they shouldn't be on this drug. And there's been a lot of hesitancy to use it in our patients that are over 65, because at one point, aren't we all at risk? So there are a lot of post-marketing studies, and I believe that's where it will shine. So if the post-marketing studies will have many, many more people, this event is either going to stand out or it's going to wash out. So at this point, that's what we're waiting for, is to get more data before we start using it widely. So treating osteoporosis. So either we treat you because you have a DEXA and we know your density is low and you're osteoporotic, or the worst thing that happens is that people have a fracture and only 1 out of 5 get offered treatment. Only 1 out of 5 are told they have osteoporosis. They just kind of get wrapped up and sent out on the street again without the appropriate counseling. So unfortunately, 50% of people that broke their hip had a fracture before their hip fracture, and there wasn't enough intervention. So starting treatment after a fracture, it should be the red flag. And, you know, even proactively knowing what your bone density is, knowing what your T-score is, very, very important, because it gives you more control over what you need. So out of 1,000 women, 500 will suffer a fracture without treatment for osteoporosis. Who should be evaluated? So women over 65. So anybody past 65 should at least have a screening DEXA. People that are younger than 65 should have a DEXA if they have inflammatory disease or if they're on any high-risk medication. And I mentioned those: steroids, seizure medications, proton pump inhibitors, thyroid medicine, and cancer chemotherapy. Or the other thing, aromatase inhibitors, which are medications used after breast cancer to prevent further breast cancer. Those medications block estrogen, so therefore increase your risk for osteoporosis. So anybody who is on these medications should be evaluated. Anyone who's had menopause before the age of 45, because we know they lost their ovarian function. So they had a early loss of estrogen and early menopause. So normal menopause is somewhere between 45 and 55. Anyone younger than 45. Now, was their menopause surgical? Still, they should be tested. What's hard is if you had your uterus out, but you still have your ovaries. That's not considered menopause, because sometimes they'll leave an ovary in so that you don't have the health problems associated with a young menopause. So we also have to think about men, because men too, anyone who's had a low trauma fracture, men with chronic inflammatory diseases, whether it be rheumatoid, celiac, bowel disease, asthma, emphysema, lupus, you know, again, anything highly inflammatory, men are equal. Steroids in men, seizure meds in men, proton pump inhibitors. any man who's had a fracture after age 50. So fractures before 50 usually are more traumatic. The other fracture that we don't really worry about is fingers and toes, because everybody breaks fingers and toes. They're not considered osteoporotic. So just so you understand, our intention is to prevent fractures, not to meet people after a fracture. And if that happens, then we try to be aggressive enough to prevent another fracture. And we understand, you know, we used to not live much past 30 because people would be eaten by dinosaurs. But now that we've perfected aging and healthcare and being healthier and doing the right thing, we can't just accept that fractures are part of natural life, because fractures really can be very debilitating and even can cause a premature loss of life. So we want to follow a healthy lifestyle. We want to do the best we can with what we can. And I think it's important that everybody know their numbers. And this is a picture of casts from fractures. And, you know, the caption was always 2 million too many. Just too many fractures are going on, and there's not enough proactive treatment and discussion about this. So I hope you enjoyed this. I hope I provided you with information that's helpful, and I believe we can field questions that Maggie might have.
Yes, yeah. Thank you so much. This has been incredibly thorough and informative, and we do have a decent amount of questions, so we'll just get to them now.
Great.
This is a really good one from Kate. What should your daily calcium intake be if you have a history of kidney stones?
You know, that's super sensitive. Studies show that if you've had kidney stones, you can still take dietary calcium in, but you should avoid supplements. So that's one thought, is that dietary calcium will not get you in trouble the way supplements will. And the second part is, if you've had kidney stones, it's a much bigger evaluation. They often want to check your vitamin D level, your parathyroid, and also your 24-hour urine calcium. Because we do excrete calcium in our urine, but some people with stones are putting too much calcium in their urine, and then they might try to adjust your diet. So I don't like to give a number. I feel like that requires, it definitely deserves a more thorough evaluation.
Okay, great. There is another one in the Q&A. So it's kind of, you can take a look, Dr. Brecher, but it's kind of a longer question. I'll just go to the end part. Can osteopenia reverse back to normal?
With treatment, yes. You know, like I said, these medications can improve your bone density by 3 to 7%. So, but just remember, and one thing I really didn't get into, there is a calculation that I'd say most of us use. We looked it up on the internet. It's called FRAX, F-R-A-X, and it's a calculation that takes into account your bone density, but also your personal risk factors, which is so important, because remember I said some people with osteopenia are not at high risk to break a bone, and other people with osteopenia are very high risk. So the FRAX calculation, and you can all Google it, F-R-A-X, it's a tool, but you need to know obviously your age and your weight and your height, if you have a family member that ever broke a hip, if you have rheumatoid arthritis, if you're on steroids, all these questions, if you drink alcohol. And then this is a very well refined, you also need to know your bone density at the neck of your hip, and all that gets plugged in, and it gives you your 10-year risk for a fracture. And we know that if your 10-year risk for hip fracture is over 3%, you should be treated. Or if your 10-year risk for a major fracture is over 20%. So most of us use that to help understand if people with osteopenia should be treated, because I will treat osteopenia in high-risk people. Now, I may get like a 57-year-old with osteopenia, and when I plug all the numbers in, it says they're not really at high risk. So they're the ones that I counsel about calcium and D and activity and say, let's get your bone density again in 2 years and make sure that it's not getting worse.
Penny has a question. Does the usefulness of the meds to strengthen bones decrease as you age?
Oh, that's a great question. There is that saying that a little is good and a lot is not good. And that's the same thing with some of these bone medications. So while I said that bisphosphonates may improve bone density, we don't like to stay on them too long, because there have been some reverse effects where it may improve certain densities, but it may make other areas weaker. So with the pills, the bisphosphonates, we will treat for 3 to 6 years, 6 years at the most, unless there's another reason to stay on longer. And with the IV form, the IV reclass or the zoledronic acid, we max out at 3 years. And that if you've not achieved our goal at 3 years, we have to talk about another treatment. Because like I said, a little is very good and too much may increase the risk for these atypical fractures.
Another one, there's a lot, but I'll try as many as in the last 5 minutes as we can. Tai Chi, is that a good exercise to do?
Excellent.
Yes.
Oh, it's excellent. First of all, it's weight bearing. Second of all, it's balance and strength. And that's everything all tied into one. So highly recommended. It's also a lot of core because posture is so important. So it incorporates everything without the risk for high impact or things that are bad on your joints. You just have to be super careful with balance. I mean, some people when they're starting out, they really need to be supported by a chair or a ballet bar. Like, you know, we're building balance.
Okay. So someone says, I see chemo causes more risk for osteoporosis. Is that only during chemo or years later? The caveat is they had chemo 17 years ago.
Oh, I think it's while you're getting it because it's an anti-metabolite. So it's trying to kill the bad cells, but you know, it also does damage to other cells along the way. And again, remember, there are things that are risk factors, but there are things that are, you know, compatible with a longer, healthier life. So yes, it's fine.
Okay. Another one is, does drinking water, plenty of water, prevent kidney stones? And then the follow-up to that one is, how often do we get our bones checked, which you may have answered during this, I think.
Yeah, does water prevent kidney stones? You know, if you have too much mineral in your urine, like too much calcium, being well hydrated with plenty of liquid is so important. And kidney stones are more common in the warmer months when people are dehydrated. So that is one factor for prevention of kidney stones, but there's a whole metabolic workup. For people who've had one stone, they don't usually do it. But if people have had multiple stones, or if I see people who've had kidney stones and they've broken bones, I'm starting to think metabolically that there's something more going on. So that's something that could be really answered better by the urologist, but plenty of fluid is always a good thing unless you have heart failure and can't have a lot of fluid. DEXAs are typically done every 2 to 3 years, and doing them much sooner. The only time we would do it sooner than 2 years is in somebody in what we call has a condition that causes rapid bone loss. And the biggest one I can tell you is people that are on daily steroids. They're going to lose bone much faster. So in those people, you might want to get them every year.
So I think we have time for one or two more. So a few people are talking about exercises that you recommend or that you discourage. You talked a little bit about that, especially if you need no high impact exercises, or if you're in a wheelchair, what would you recommend or discourage?
Gosh, I mean, if you're able, let's start with able-bodied, walking in place. You know, there's a lot of those walking programs that you can do. Anything where you're working in post-gravity, walking outdoors, mall walking in the winter. A lot of our malls will open early for mall walkers, so we don't have to worry about the ice or the cold. Walking is super, super helpful. The other thing is, think about what you do every day. You know, a little bit of housekeeping, up and down the steps, gardening, things that you're doing that you know, I always say to people, do you exercise? And they say, no. I said, well, tell me what you do in an average day. And these people never sit down. Well, that's activity. You get credit for that. So running in and out, going to the store, supermarket shopping, all good for you. Strength training, sometimes I like to refer people to physical therapy just to learn what's right. You know, I don't want somebody to go pick up 10-pound weights, which are going to put too much stress on their back and their vertebrae. You know, we have the tendency to overdo it, to jump into things. So getting an exercise prescription, I find very helpful. People that are wheelchair bound, I still think that there's a lot of things you can do to strengthen your muscles. You know, there are some exercises you can do just by lifting one leg and holding it straight out there while your back is nice and supported by the back of your chair. That helps to build up your quadriceps or your thigh muscles, which are important to support your knees and your hips. Sometimes using little hand weights, 1 pound hand weights, you know, things like that can improve your upper body strength. Because, and the other piece is just sitting up strong, sitting up straight as you can, not to slump and not to bend forward. You know, like I said, physical therapists are, at this point, a lot of them have doctorates in physical therapy, and they are so well trained to be my partners in teaching you what to do, and they're great cheerleaders, and they can actually work with you. And so I will tell you, Medicare covers physical therapy, and I usually encourage people to meet with a professional, whether it be, we sometimes send physical therapists out to people's homes to help us. We'll do like a PT home evaluation and OT to measure safety in the home. You know, is there enough lighting? Do they need grab bars? Somebody going out to the house helps me a great deal, because then I can make recommendations.
Okay, great. Yeah, I have heard from a lot of constituents how life-changing physical therapy has been for them. So my final question, can you just talk a little bit more about the best vitamins to take?
Are we talking in terms of calcium and D?
Sure. So one of them in particular is, if your kid has lupus and has a low level of vitamin D, should they be taking a calcium supplement daily? And then
Child?
Child? Yeah, child. And then another one is, what's the best kind of vitamins to take?
Yeah, I mean, I always, especially in children, I so much prefer diet. If we get it through food, it's much more natural, and I know they're going to grow more and they'll do better with dietary products. In terms of supplement in children, I definitely would talk to the treating physician. Vitamin D, same thing. There should be a level done before we just kind of go willy-nilly about supplements, because there's certain vitamins that if you get too much in them, they can be toxic. And that's vitamin A, vitamin D, vitamin E, and vitamin K. They're what we call fat-soluble vitamins. So if you take too much of one of them, they actually accumulate in your fat and they stay with you. Whereas if you take too much B or C and all the other things, we call them water-soluble vitamins. So if you take too much of those, you're just going to have very expensive urine, but your body will clear it. So vitamin D really should be pretty much not by prescription per se, but your provider should help you understand your specific situation. Now with lupus, there's some very wonderful studies by Dr. Petrie out of Hopkins that shows that people with lupus should try and maintain a vitamin D level at about 40. That decreases the risk for lupus flares and specifically for kidney flares. So I pretty much am crazy about that in lupus patients, to try and maintain it's a 25 OH vitamin D at about 40. I think that's pretty good insurance that it'll help your health. Vitamins are tough because they're not FDA regulated, and it makes it super hard to make recommendations on that. I try to stay with the bigger brand names, as crazy as that seems, but a lot of them have like USP designation, you know, OzCal, Caltrate. The other thing, Tums are full of calcium, but unlike the other vitamins, Tums don't have vitamin D in them. So if, you know, you're probably going to have to up your D, but most multivitamins have a certain amount of calcium and a certain amount of vitamin D. So when you're making your list of how much calcium and D you're getting, don't forget to look at your multi, because if you're doing like a woman's vitamin, that has a little extra, like the silver, like the Centrum silver, and the difference with young women vitamins and older women vitamins is once you're past menopause, they don't throw iron in the multivitamin because you're no longer having menstrual loss. You don't need iron. And they add extra calcium and D because they realize you're postmenopausal. So it doesn't have to be Centrum Silver, but that's just the example I use. A lot of different vitamin companies will make a vitamin for the over 50, and that's the whole difference. No iron, extra calcium, extra D.
Thank you. You just fit so many questions into 10 minutes.
Wonderful.
I'm so grateful.
Well, God, I so appreciate the questions. I hope you understand I'm very passionate about education. I think the more you understand, the easier it is for you to do the right thing. So I do appreciate the attention.
So thank you. So thank you so much again to everyone who tuned in tonight. This will be edited. I get it edited by tomorrow and send it out. And the chapters will have it and send it out to you. Dr. Brecher, thank you again. This was, again, so informative. The comments are lighting up in praise of you.
Thank you. I so appreciate that. I'm just happy to be here. That's just, it's great.
Awesome. So the next Let's Talk About It is going to be July 13th. We're going to be talking about Medicare. So I hope to see you all then, and everyone have a great night.
Good night.
Bye.